Thanks, first of all, for having me and inviting me on this great first ESCO meeting. I would like to congratulate the organizers for putting together such a nice and exciting program, and I'm very happy to be part of it. So today we will discuss and shed light on the futures of inflammatory bowel disease, and then more specifically, we will focus on precision medicine in IBD with a detailed focus on diagnosis, and to me, this also includes disease outcomes. What I want to today is dive into the guidelines on how to diagnose inflammatory bowel disease. I think you're all familiar with the ECHO guidelines, which we published a few years ago on how you should diagnose and assess your patients with inflammatory bowel disease, including a very recent topical review on differential diagnosis. But that's obviously not the scope of today. The question is, what are the potential precision medicine tools when it comes to IBD diagnostics? And I think, in all honesty, at this stage in our daily clinical practice, we should say, well, there are no clear precision medicine tools when it comes to diagnostics. And if we think also what is currently stated about this in the current ECHO guidelines, and we stated a few years ago already that at this stage that genetic or serologic testing is not recommended. And the reason why we decided to recommend against this is mainly because if we, for instance, look at IBD genetics and we compare polygenetic risk scores of individuals without and with inflammatory bowel disease, then you can appreciate over here that there is a huge overlap in genetics, which means that genetics alone will at this stage not yet help a lot in further refining our diagnosis. I know when I realize that a lot of research is being done in this domain, and it might well be that in future things will change, but at this stage, genetics are not yet part of our diagnostic armamentarium when it comes to diagnosing inflammatory bowel disease. However, as I told you, a lot is changing, and one example I could present you are data we very recently reported and presented at the last ECHO conference on potential non-invasive diagnostic markers. So imagine we all have to do intestinal ultrasound, MR angiography, and or endoscopy to come up with a diagnosis of inflammatory bowel disease. And this is obviously yet the golden standard. However, it might well be that in future we can use non-invasive tools at least to further refine and to further select patients in whom an invasive endoscopy, for instance, could be recommended, but already exclude those who don't need it because the likelihood of, for instance, irritable bowel syndrome is much more likely. So the data we presented at ECHO very recently are focused on exosome, extracellular RNAs, which are circulating throughout our blood, and in a very tiny amount of serum. So this was only 3 to 10 microliters of serum, we will basically able to detect a lot of extracellular RNAs, and with a panel of just 8, we could split patients with Crohn's disease and ulcerative colitis with very high accuracy. And I realize obviously this needs further validation, but this is just one example on how novel technologies might help us in future to further invest on non-invasive markets, either in the diagnostic process, but also in the prognostic process, and in many more clinical scenarios in inflammatory bowel disease. And why is this important? Because obviously the incidence and the prevalence of inflammatory bowel disease specifically is very rapidly increasing. As you can see over here on this graph, there is a very steep rise. And the question will we be plateauing around 2015 in our Western world, or will we still see a further steep increase in prevalence? And the same applies, although at slower steep yet, in newly industrialized countries and also in developing countries. So we will see more and more patients with inflammatory bowel disease in our clinic. So we will need to rethink how we will classify them, how we will monitor and treat them, because I think anno 2021, we can no longer accept a one-size-fits-all principle for our patients. And I think all of you seeing patients in clinic on a regular basis, you all can appreciate that not all patients require the same monitoring tools, the same prognostic tools, the same therapeutic algorithm. So I don't need to convince you that inflammatory bowel disease is a very heterogeneous entity. And that's why I think we need to rethink our clinical classification systems, as they have a lot of shortcomings. And we have to aim for a better molecular understanding so we can stratify patients right from diagnosis onwards and search for biomarkers, ideally non-invasive. And as I said, to me, when it comes to diagnosis, it's not just diagnosing a patient with inflammatory bowel disease, because I think at this stage, we are quite confident in the vast majority of our patients that we make the diagnosis right, although potentially a little bit too late, but I'll come back to that later. But at least as we diagnose a patient, it would be very informative if we also had prognostic markers. And I don't have time today to go through all these various markers, so I will focus on just one, a marker for me, which has quite promising data until now, and which potentially might be the nearest in the future to make it on into our daily clinical practice. And the marker I'm talking about is a prognostic marker, which was already published 10 years ago by the Cambridge group, where they reported on a T cell marker, a CD8 T cell marker linked to T cell exhaustion in patients with inflammatory bowel disease, but as well in patients with ANCA-associated vasculitis and systemic lupus. And in an unsupervised manner, they looked at gene expression of these CD8 T cells, and they clearly could identify two large groups of patients, and they called them the IBD1s and the IBD2s. The IBD1s turned out to have a more aggressive disease phenotype, requiring surgery, requiring escalation towards biologicals, whereas the IBD2s had a very mild disease course, with no surgery, of less surgery, and with, for instance, for UC, only the need for 5-ASA therapy. And so these two distinct groups, which they could basically derive based on transcriptional signatures, could then be identified both in patients with Crohn's disease as in patients with ulcerative colitis, as you can appreciate on the current Kaplan-Meier curves. And these two groups are splitting apart based on their need for dose escalation. So the molecular phenotype is reflecting what's going on in these patients in daily clinical practice. But of course, imagine if you have a CD8 T cell marker, that's all very nice, and I think the scientific story behind is fantastic. However, to make that happen in our daily practice, this is not feasible. If you first have to take blood, isolate PBMCs, sort CD8 T cells, and then run sequencing experiments, that won't be feasible at all. So they converted their initial CD8 T cell signature into a whole blood test. So that whole blood test has been further narrowed down, and ultimately they ended up with only 70 genes which could replicate their CD8 T cell signature. So they have in the meantime validated this in a cohort of CD patients and UC patients, where they could estimate with a high likelihood whether the patient belonged to the IBD 1 or IBD2. And this has then also been replicated in a larger UK real-life study, where again IBD1 and IBD2 basically split apart in terms of their escalation-free survival. So this promising whole blood test, which has already been commercialized in Europe, is currently undergoing, I think, a very important trial assessment. This is the first biomarker-driven trial in inflammatory bowel disease, especially in the prognostic domain, where patients are diagnosed with active Crohn's disease. The biomarker is assessed. They will have 200 patients in the IBD high group, so the ones with the very severe, the predicted severe course, and 200 with the predicted moderate disease course. And then these patients will be randomized either in a step-up or a top-down strategy. And the aim of the study is to show that in patients with a predicted severe disease course, hitting the disease right hard from the start with a top-down strategy will make a difference ultimately at week 48 in steroid and surgery-free remission. So obviously we have to await the results of the trial, but I think at this stage, these are very promising and encouraging data. And if the trial turns out to be positive, this will definitely be a landmark trial and change our treatment paradigms in inflammatory bowel disease for the future, right from diagnosis. However, if we think about diagnosis, I've told you that we are quite accurate at this stage to diagnose when a patient has symptoms, when a patient has elevated fecal calprotectin, and then we can see that there are endoscopic lesions. Sometimes it immediately requires surgery or, for instance, a balloon dilation if a patient presents with a stricture. But of course, this means that a patient has been suffering quite a while. And we know, especially in Crohn's disease, more than in UC, that there is a diagnostic delay. And that basically there is a large phase before that clinical phase, the preclinical phase. So there are many patients at risk, but there is only a subset of individuals in whom basically the disease ultimately initiates and then further expands until the patient gets symptoms. And that's basically, I think, where a lot of the current unmet needs in the diagnostics of inflammatory bowel disease lie. So we need to better understand molecularly what's going on preclinically so we can hopefully intervene and potentially either predict or ultimately prevent the disease to give symptoms in these individuals. And I think one of the key experts in this field is Joanna Torres, together with Jean-Fred Colombel, who both have done a lot of work together with many more colleagues, trying to understand and to map what's basically going on in that preclinical phase. So how should we study that preclinical phase? I think there are two big scenarios. So there is one scenario in which we focus on high-risk populations, so first-degree relatives, for instance. In other words, obviously, we have these large cohorts of patients we can evaluate prospectively, or if you have a biobank, you can look back retrospectively and then focus on patients who ultimately, or individuals who ultimately developed symptoms and were diagnosed with inflammatory bowel disease. And there are many projects ongoing, so I don't have the time today to go through all of these projects. So I will just give you a few examples to give you a sense and a flavor of what's ongoing at the moment in that era of unmet need in the preclinical phase. So a few projects are focusing specifically in the prenatal phase and the infancy of individuals who ultimately might develop inflammatory bowel disease. Then there are other projects like the GEM project, who focus specifically on the transitions from childhood towards adults and subsequently follows patients into their adulthood. And then finally, one of the largest projects until now in this space is obviously the PREDICT study, which is addressing specifically inflammatory bowel disease in the adult population. So let's first have a look at studies in at-risk populations. So I think the key example is the GEM project you might have heard from. This is a beautiful project led by Ken Criterio in Canada. So what they basically wanted to do is to follow a lot of healthy individuals and monitor them in how many of those ultimately inflammatory bowel disease would be diagnosed. And obviously, given the current prevalence, that these are very ambitious projects. So they try to enrich already for identifying a few cases, and therefore they focus specifically on siblings of patients who are diagnosed with inflammatory bowel disease, so their first-degree relatives. So they had a higher chance of picking up a few cases. And ultimately, so this study has now been completed. They identified 75 new cases, and they had a lot of matched age and gender controls, so they could make comparisons. What are the differences? Why someone basically developed the disease and others didn't? So being from a multiplex family, having an altered intestinal permeability and a microbiome diversity might be risk factors for development of Crohn's disease based on the results of this GEM project. And I'm not telling you what's cause or consequence, because that's very difficult to tease out, but at least these are risk factors, and it might well be that these are individuals who we should monitor more closely and potentially also should consider for potential interventional studies in the future. So what, for instance, the GEM project showed that if you have a high group of asymptomatic first-degree relatives, at time of inclusion, they collected their urine after a lactose mannitol test to assess their intestinal permeability. And what they could demonstrate is that if you have a normal barrier function, at inclusion, that your likelihood to remain asymptomatic is much, much higher. Whereas if you have an impaired barrier function already, being a first degree relative, your chances of developing a Crohn's disease at a later stage are much, much higher, as also depicted on that Kaplan-Meier curve. So this is just one example of studies which are focusing on high-risk individuals. But on top of that, there are a lot of studies in the general population. And as I already alluded to, this PREDICT study is, I think, one of the key studies in this area until now, led by Joanna Torres and Jean-Frédéric Colombel at Mount Sinai, New York. And they had a brilliant idea of basically reaching out to the American Army. So the American Army, in all their employees, they are every 2 years, they are taking blood. So there is a lot of blood being stored in their repositories. And obviously, they also have medical data. So what Jean-Fred and Joanna could do, they had access to the anonymous data and could identify individuals who were diagnosed at a given stage with inflammatory bowel disease. And because of the biobank repository, they could go back in time and request a serum sample, which were longitudinally stored in these individuals. And then they run a lot of proteomic tests, and they could compare those with a population of healthy individuals, again from the American Army, with the same length of follow-up, but who did not develop inflammatory bowel disease until now. So, and what they identified was that there are many proteins already differentially expressed in the years before a diagnosis of inflammatory bowel disease is made. And they identified 6 markers who were common to the 5 time points before diagnosis, from year 1 to year 5. And then they constructed predictive models. And as you can see, I think the accuracy is quite astonishing, bearing in mind that they are trying to predict a disease which will be diagnosed 5 years later. However, and this was quite surprising, when they repeated the analysis but focusing on UC instead of Crohn's disease, they couldn't identify any single marker which was robustly differentially expressed and predictive for a potential future diagnosis of ulcerative colitis. So, and there are a lot of hypotheses, whereas it's linked to the transmural character of Crohn's versus the causal character of ulcerative colitis. But I think a lot more research has to be done in that domain to further understand, especially because very recently, in the last days, there was another publication coming from our Sweden friend, led by Jonas Halvarsson and his group, where they had access to a large biobank of healthy individuals who were longitudinally and prospectively followed up. The majority remained healthy, but a few were diagnosed with ulcerative colitis. And if they looked at a lot of inflammatory proteins in the years preceding that diagnosis of ulcerative colitis, they could identify a robust signature that they could validate in a UC inception cohort. And on top of that, if they looked at these 6 proteins in a cohort of twin siblings from UC patients who did not have any symptoms, again, these proteins were upregulated. So it seems that at least we get a sense in terms of the proteome of potential markers which could be used to identify and diagnose UC and CD in a preclinical phase. However, I don't have to convince you that inflammatory bowel disease is a very complex entity where there is a lot of interaction between environmental factors, the immune system, genetics. So it gets very complicated, especially when we consider the environment. So in one study, which tries to address part of the environmental factors, is the meconium study, where they follow prospectively mothers with and without inflammatory bowel disease. These mothers are intensively sampled throughout pregnancy, but also their babies after birth are also repeatedly sampled, as specifically in stools. And this is, oh, sorry. So it appears that the graphs have not been represented on these slide, but still I can explain you what they did. So they looked longitudinally at the baby's microbiome profile in the first months up to 25 months after birth. And what they identified was that the influence of the mode of delivery on the composition of the microbiome basically decreased over time, whereas the importance of the type of feeding, the preterm birth, and the diagnosis of having a mother with inflammatory bowel disease basically much more affected the composition of their microbiome over time. So it seems that there are a lot of environmental factors which play a key role in, for instance, the composition of the microbiome already during infancy. And having a mother with inflammatory bowel disease is one of the key factors affecting that. So if we have to think about how can we study the environmental factors, this is obviously very challenging, even more challenging than all the non-invasive technologies we are currently performing, because obviously when you're diagnosed as an adult with inflammatory bowel disease, you cannot recall, and no one will ever be able to tell you what you have been exposed to in utero, during your childhood, etc., etc. So again, Joanna Torres came up with a very smart idea where they basically focus on teeth. So similar to the rings of a tree, you can basically do the same with teeth. And in Portugal, there is a tradition of when teeth are being shed around 6 years of age, these teeth are preserved, so your parents keep them for you. So if at a later stage in life you're diagnosed with inflammatory bowel disease, you can basically go back to these teeth and you can ring the concept of the ring of a tree. And with novel technologies, you're basically able to identify metals, organics, and metabolomics in these teeth, which have been preserved for years. And this will give a lot of information on the prenatal exposure to environmental factors and the exposure of these kids in their early life. So what they will do now, and this is an ongoing project, so they will compare a lot of these metals, organics, and metabolomics in teeth from 100 individuals with IBD and 100 controls. And obviously, and this is, I'm almost at the end of my presentation, obviously it might seem ambitious that we try to predict and prevent inflammatory bowel disease, and this might sound a little bit futuristic. However, this is already happening in other immune-mediated disorders. And these are just two examples, one from type 1 diabetes and one from RA, where, for instance, in individuals at high risk for the development of type 1 diabetes, with a single administration of a given drug, they delayed significantly the time to diagnosis. So it seems that we are able, at least if we can first of all understand what's going on in this preclinical phase, that we can intervene and that we can hopefully prevent. And if we cannot prevent the disease in all individuals, then I think we should aim to have a timely diagnosis. And there again, these non-invasive markers also in the preclinical phase might definitely help. And once a patient is diagnosed, prognostic markers are so important to basically stratify the patient in terms of how their disease course will look like, so we can basically react much more on their molecular phenotype and provide them with a therapeutic strategy which entirely fits onto their molecular fingerprint. So in conclusion, dear chairman, dear colleagues, I hope I've convinced you, and many of my colleagues during the other talks will do so, I'm sure. Precision medicine in IBD is happening also in that pre-diagnostic and prognostic phase, but there are, of course, a lot of hurdles we still have to take. Biomarkers and predictive algorithms should obviously have a very high predictive value and accuracy if we should consider to intervene in that preclinical phase in order to justify the potential adverse events from screening and intervention. And obviously, we need a better molecular and biological understanding of a lot of components in inflammatory bowel disease, including disease heterogeneity, the natural history of the disease right from the start, also in its preclinical phase. And we obviously also need a better understanding of which therapies or interventions can ameliorate or reverse the changes in the preclinical phase. And obviously we have to incorporate also patient associations, and we should discuss with them what are basically the therapies and preventive measures high-risk individuals will be willing to accept when faced a probability of developing disease. So I hope I've convinced you that this is a lot of work in progress, but this is obviously something which no one can do alone. And therefore, I'm very happy that back in 2020, just before the pandemic started, we had that beautiful meeting, the Echo Scientific Workshop, which has now resulted in the Echo Precision Medicine Task Force. And I hope that as a group with many people around the world, and we are very open and keen to have many more people being involved, that we can do this together and that we ultimately can make a difference for our patients. So with this, I would like to thank you for your attention. I would like to thank all people involved in the Echo Precision Medicine Task Force. And I also would like to thank all my colleagues in Leuven. And with this, I'm very happy to answer any questions. Unfortunately, I can't be there today face to face. So either you can send me an email or you can contact me via Twitter, or you can find us through our IBD Leuven website. But I'm more than happy to further discuss this with you in a Zoom call or a face-to-face discussion, hopefully next year in Egypt. So thank you for your attention. Bye.
Thank you.